we are exhausted. I mean, I'll just flat out tell you, we are exhausted.
Yeah.
And exhilarated. If you can carry both of those at the same time.
Well, I chose to do my internship at Cook County Hospital in Chicago, which is the great big public hospital. And it was brutal. But in some ways it was the best job I ever had, because I was, arm in arm with my comrades fighting the good fight. And
yeah, exactly. And that is exactly how people feel here.
Yeah.
If you get a chance, go to our Facebook page and look at the video from the city of Evans and the video that we posted. This week on Tuesday. So to tell this story, if you don't mind.
Hang on, before you do, let's get you introduced. Just say who you are. Okay. Today is April 24th, 2020. And say who you are, where you work, what you do.
Okay. So I'm Mitzi Moran. I serve as the CEO of Sunrise Community Health. And Sunrise is a federally qualified health center serving 42,000 people each year in northern Colorado, Weld, Larimer, and the surrounding counties. Our mission is to provide affordable access to quality care for all. So we are targeting people who are uninsured or underinsured, and we believe that accessing the right care at the right time at the right place is a right, not a privilege. And that is our mission. So we are standing steady in the storm. I often say we are a port in the storm for our patients every day, and especially when it's raging. And so right now that is particularly true. 27% of our patients have no insurance whatsoever, so they can go nowhere else for care. Many of our patients have complex health conditions. And just because COVID is here, those things aren't going away. So we have to make sure that our prenatal patients are getting care, that our young kids are getting their immunizations, that our asthmatic and our diabetic patients and hypertension, that all that care is being well managed. So those people are as equipped as they can be to fight COVID should they get infected. So we're standing steady in that spot, but we're also standing steady in providing respiratory care and doing COVID testing. We firmly believe that we have to own our spot in this healthcare system, so we don't so our patients don't overwhelm the emergency room or the hospital or the critical care systems with things that aren't critical right now, if they had gotten care in the primary care setting. So we are open, we are serving our patients, we are accepting new patients. Now the way we're doing that though, Mark, is we have retooled our service delivery in the last 8 weeks, primarily in the first 4 weeks of that period, in incredible ways. We launched telehealth. We had never done that before. We condensed from 11 clinics to 6, and in those 6 clinics, diverted all respiratory to only 2, and then rechanged the entire flow in those clinics to handle respiratory clinics separate and isolated away from non-respiratory patients. We implemented a pharmacy grab-and-go system where patients can pull up and text us, and we'll run those meds out to them as opposed to them having to come in the building to get them. We've implemented a lab and go where it's same thing, point of care testing at the curbside. We have retrained everyone on respiratory care and PPE and how to make sure we're safe and patients are safe, and all in a matter of, well, out of all those projects, we set up like 5 of them in 7 days. And you know how healthcare is. If I would have asked at any other time, hey, I need you to get pharmacy grab and go done by tomorrow, there would have been mutiny, right? There's no way systems move that quick. So the team, this is what makes me exhilarated, is the team has risen to this occasion in just ways that are so moving and so inspirational. I am so proud to serve on this team.
So it looks to me like you're sitting at your desk at work, right?
I am.
Yeah, you're wearing a name tag and everything. So you've been going in every day?
I have not been. Yes, I work in the office every day. twofold. One, I can social distance well here. So we are a good 6 feet apart. Plus, we have now implemented social comfort masking. So we have that. And I feel strongly that if we're asking our clinical team members to serve in the office, I need to stand alongside them, following the rules, making sure that I'm being safe, making sure that I'm not infecting them. So we've done a pretty good job of making sure it's a safe environment. We have no meetings over 10 people, if even that. We have no queues. If we do, they are 6+ feet staged apart. But you walk in the clinic and it doesn't look like, we don't have large groups of people anywhere in the building. The departments that couldn't do that kind of social distancing, then we have done telecommuting to make sure that when they are here, they are appropriately spread apart. And if their space does not allow that, then they're at home. As of last week, we're about 63% of our visits are telehealth. So we have converted to that quickly.
And when you say telehealth, do you mean interactive video, or do you include telephone in that?
Right now, it's been phone only, but starting this week, we started piloting the video. So next week, there will be more video offered.
And have you been able to, with your complex payer mix and unusual for a system that's driven by the private sector, do you get paid for any of this?
You know, before this, no. Telehealth was not covered. We would not get paid our federally qualified health center rate from Medicaid, but that is an exception that they made during the COVID crisis for us. And it is a lifesaver for patients so they can connect to their primary care home. And it helps us then be able to fund keeping these doors open so we can stand steady to serve.
How many of your providers at one time are working from home versus working at one of your clinical sites?
Well, about 25% of each pod. So a pod would have 4 on in a day. One per pod is working from home. Because it's really a hard balance because we are still open and serving. If you have telecommuter and you have someone on PTO and then you have someone get sick, you don't have enough staff on site, and you won't know that until maybe the morning of. But the people that are on site, more than half of their work is being done telecommuting. So they are secured in their exam room and doing telecommuting. So we've got them distanced appropriately when on site, but they're also here ready to serve depending on what walks in the door.
It can be necessary, yes. And it sounds like morale is very good. Have there been issues?
You know, that's the story I was going to tell you is, yes, morale is good. The team is leaning in with courage and compassion. I mean, it is so inspiring, but they're scared. Yeah. Some people rise to this occasion and some people, this is not where they shine, but everybody is scared. You don't know, it's unprecedented. Our respiratory clinic, our walk-in at our largest clinic has about 70 to 80 people a day that are walking in. And of that, about 80% is respiratory.
Really?
Now, not all of that's COVID respiratory, right? So there's a screening process. And from there, you walk in the door and you are screened immediately. You don't even get 2 steps in. Do you have this, or this? You go this way. If you don't have it, you can go that way. And you're masked and you're sent into respiratory. From there, there's another screening process. But I would say, I could actually look to tell you, but I think about 30%, 40% of that respiratory is COVID related. We've tested close to 600 patients so far. And we began with a very prescriptive testing criteria because there weren't enough tests.
Right.
That has broadened over time, and we are getting more tests in, and test results are coming back quicker. So to date, we have tested just over 600 patients. This is not counting yesterday or today. And about 40% positive, about 40% negative, and we've got the rest are undetermined. We just don't have the results back yet.
40%?
Yeah, but But think about that though. If the testing criteria is really tight,
Right.
you are going to get higher positive because you're narrowing down to the most likely.
Right.
We have at the beginning had to tell people there aren't enough tests, but we believe you have COVID, so presume you have it. Go home with good self-care, follow these guidelines, and then anybody, whether they actually have the confirmed test or we suspect COVID, our care managers are calling and following up with them to make sure that they're all right.
And how many patients have wound up hospitalized?
I don't know that off the top of my head. I don't know that. Sorry.
Or do you know of any that have died?
Yes, we have had at least one patient that has passed because of COVID.
Yes.
Or COVID and complicating factors. Yeah.
Right.
Yeah.
How are the patients?
You know, they're scared as well. There's just a lot of fear. And the ones, I don't have it. This is not our numbers, but this is how I've been framing it in my brain. We all are going to get exposed to COVID, and about 50% of us are going to get sick. And of that 50%, 80% will recover fine. It'll be some kind of a cold type scenario. But the 20% who get sick, they are really sick.
Yes.
Really sick. And we're seeing that as they walk into our respiratory clinic. There is some severe illness that's coming through the doors. And we're either getting them directly to the hospitals, calling EMS for them. One morning, I think we had 3 calls to EMS.
Mm-hmm.
Yeah. The other thing, the patients are extremely, extremely grateful for us being open. Our prescriptions, we have done about 1,000 more. Well, no, sorry, that's not right. About 2,000 more prescriptions in the last 8 weeks than compared to those same 8 weeks in 2019.
Mm-hmm.
Our phone calls are up by about 1,000. Our no-show rate and our cancel rate is down by double digits, both of them. So your patient, and they're adapting to telehealth, and our visits are holding pretty steady.
Mm-hmm.
Between the telehealth and the on-site visits are holding pretty steady. Now, it didn't. It started at the beginning, dipped clear down to about 70%, and then it's coming back up. Dental has dropped to 15% of capacity, right? So that department has been hit extremely hard. So all of those things that I just mentioned, though, the no-show rate, the cancellation rate, the calls to the clinics, the number of visits that we're seeing, prescriptions up, et cetera, all of those are signs that our patients are saying, we need you, right? Mm-hmm. But we also are getting direct feedback from them. I mean, we had one woman just in tears. She said, I work at a nursing home. I have to get there. I have to know that my daughter has strep or not. Thank you for being open. Because you know her well, you know my family. I am so glad I could come to our primary care office. You know, just lots of positive and appreciative feedback like that.
So it seems pretty obvious to me, you haven't had to lay anybody off or furlough anybody.
We did in dental.
In dental.
Because in dental we did, but minor. We laid off 5 positions, eliminated some open positions, but the remaining 33 dental team members have a minor amount of furloughing, and what we've mostly done is try to retrain or redeploy them to other roles. Mm-hmm. So we have dentists that are helping with protocol-driven pharmacy refills. We have a dental hygienist who's helping with our OOC group, care management. We've got dental assistants who are the runners for the grab and go program, the pharmacy grab and go program. Mm-hmm. So we're trying to retrain and redeploy to keep people at full income and full benefits.
Mm-hmm. How do you think, who knows when this is going to be over? And that's not the question I'm going to ask you.
Yeah.
If you answered, I would know you were...
shooting in the dark.
Yeah. But how do you think healthcare will have changed when this is all over? How will your role have changed?
Yeah.
In this?
So when this started, I said 2 things to the team. I said, 1, this is going to shine a light on where we are polished, and it's going to shine a light on where we are not so polished. So hang on and realize it's okay. As soon as we identify those spots where it's polished, we're going to start polishing. And the other thing was, it's never going to be the same again. It is not going to be the same. So for example, telehealth is a really good example. This tool is helping us reach people. Set COVID aside, it is helping us reach people that for transportation reasons, for whatever, could not get to the clinic, and they were people we couldn't reach. That is a tool I hope continues. That's an important tool to help us keep people connected to primary care, as opposed to waiting until the depth and breadth of disease is so strong or so deep that they have to go to the emergency room and then get hospitalized. If we can have a better connection to them, we stand a much better chance of managing their care at the right time, right place, right cost kind of thing. So that's a good example. How has it changed my role? I actually am looking at our org structure as a result of this. We have a pretty flat org structure anyway. I think I want to flatten it a little bit more. Watching how vitally important it is to have leadership on campus, in person, and the way we're structured doesn't allow that as much. So I was previously looking at the org chart anyways, but this has really spurred me on to rethink how we communicate, how leadership is assigned to each campus. So I'm not sure where it'll land, but it's going to be different than it was before.
So that's interesting, because on the one hand, we're saying that as far as providers go, they may not be around as much because they can do a fair amount of their work remotely. And as far as administrative staff go, you want them to be around more.
Well, and the provider part, though, it's interesting because several of our providers have said, I don't really want to telecommute. All the tools are here. My MA, who's bilingual, it's easier if she's just here with me and we're working exam room by exam room. If I need other languages, you're in demand. The video in demand is easier to attain here at work than it is to try to do it from home. So I don't have the home environment that would let me see patients all day uninterrupted in a professional way. Sometimes they'd like to do that, but for the most of them had said, I'd prefer to do it here. Mm-hmm. So I'm not sure that we will end with providers not being on site, but they still might be doing more telemedicine. Mm-hmm. But like, we have worked really hard to try to get morning huddles to be valued and attended, mm-hmm. right? They are attended every single day with intense attention every day during this. Mm-hmm. And it is cementing communication mode. It is, I think, setting some expectations for some turnaround on data quicker and faster so we can make decisions and adjust real time. I mean, if I would have told the team I want pharmacy grab and go up within a week, that would have been mutiny. And we got it done in days. And part of it is because of how we're turning data around, how we are unified on a single focus right now. How do you keep some of that energy? The other part of that I'm really interested in is we have not let perfect get in the way of progress. Mm-hmm. And how do you keep that energy going, right? Not having the crisis drive it. How do you just have that culture? So it'll be interesting to see how this post-COVID goes. Yeah,
when everybody stops and takes a deep breath and
yeah. And now, there's no way I think we can keep up the pace we've been keeping. There's just absolutely no way. People are exhausted. But we could go a little faster than we were, obviously, because look at what we've got done.
Mitzi, how much are you working?
This week was better. The first 4 weeks were 60 to 70 hours kind of weeks. Mm-hmm. 12, 15-hour days there for a while.
And what did you used to do?
50-ish.
Back in the old days.
Yeah, but between 40 and 50. I hung right in there on an average, maybe closer to 50, but set right in there. And that would be true for my entire exec team. But those first 4 weeks, it was nothing close to that. It was way more. Yeah.
Have you had anybody among your employees, anybody among the staff who just couldn't take it, who left, who ran away?
We have had a couple team members that have, they didn't run away, but they have not been able to cope as well, and we've asked them to then take PTO and do what you need to do.
Mm-hmm.
We did right away. I think that was one of our second actions when this broke. People's fears first were, am I going to be infected? And if I am, and I have to be home, am I going to be paid? And so we, thank God, our PPE has been solid. I know that is not true for all healthcare providers, but we are so thankful that ours has. So that helped, right? People aren't reusing PPE here. We're not having to limit what we can do because of a lack of supplies. So that was very helpful. And then 2, we immediately gave extra PTO and extended illness hours for our leave without pay program, so people could be reassured and then not come in when sick. We encourage people, please stay home, stay home, stay home, because if we are going to have patients coming in and we got staff here, we need to make sure that you have a way to stay home. Yeah. Or if you're worried about a family member who's ill, you have a way to stay home. And our call-ins, our COVID-related illnesses or absences, COVID-related absences, they started out and they peaked, and we're coming back down off of those right now.
Mm-hmm. How long ago did they peak?
Let me tell you. I would say about 2 to 3 weeks ago was when we were having the highest number of call-ins. And kind of right after we gave the PTO and EIB, mm-hmm. then within 2 weeks, a lot of people took it right away. Mm-hmm. As to be expected, and that's okay. That's why we wanted them to have the tool. Not all of them went out because they were ill. Some of them went out because I don't have daycare for my kids and I've got to get that figured out, or I need to take care of mom, or whatever the case may be. It wasn't that it was all illness. Mm-hmm. And it's coming, it's like the COVID curve. You see, it went like this and it came back down like that. I will tell you what I'm worried about is if Weld opens too soon, mm-hmm. We will have another peak of. I
was forwarded the newspaper article today.
Yeah. I'm really worried about that. For our hospital partners, for everybody.
Yeah. Besides the benefits, which is of course most important, what have you taken some other steps to support staff? What sorts of things have you? I just talked to a guy today who told me they had made it extra important to keep the chocolate drawer full. And that's a drug that so far there have been no shortages of, as far as I've heard.
Yeah, no, we are doing treats or some expression of appreciation every week. So last week it was breakfast, or this week it was breakfast burritos. Next week we've got some sunrise t-shirts that say sunrise, hashtag sunrise strong, hashtag sunrise 4th day on them. We have done popsicles, and we've done, just once a week, we're feeding them some kind of treat, a thank you of appreciation. But now, this is the story I was going to tell you. So because we've moved all our respiratory down to the South Clinic, our North Clinic, one of the medical assistants up there said, you know what, we should do a drive-by parade for the people down at the South Campus. Mm-hmm. Let's surprise them and tell them thank you, because they're seeing all the respiratory for us. And so that got arranged as a surprise, and we were planning on doing a fire drill to get everybody out of the building so they could see the cars, our employees, driving by. And we have one officer here from the Evans Police Department, Officer Garcia, and he has just become one of us, because I don't know if you knew that, but we helped facilitate that the cold weather shelter get located on this campus next to us. Mm-hmm. And so he's here often because of the complexities of that population. And at first he was a little, kind of negative about it, having to come. But he has become a convert, believes in what we do, believes in Sunrise. We need to give the man a name tag. He just comes in the clinic. He knows everybody. Everybody knows him. So when this parade was getting arranged, one of our directors called him and said, hey, just wanted you to know, and would you want to drive in it? You want to just drive your car in it? He said, yeah, and I might bring some friends. We're like, okay. He brought full force. I think 4 fire departments showed, EMS showed, and there was not a dry eye in that parking lot, Mark, when they realized it wasn't just a fire drill and they saw that coming through, full lights, full sirens, in appreciation of what they're doing. It was so touching. And I know that maybe sounds kind of silly or something, but people were so touched. They're so tired. They're so committed to what they're doing, and to be recognized externally by partners. You know, we see the police and particularly EMS as our partners. They were really touched. So go to our Facebook page and watch the video. It's great. It is just great.
Yeah.
So things like that make a difference.
Are your providers and other clinical staff working more hours too, or are they tired mostly just from the strain of what it is that they're doing?
Just from the worry and the strain, because they're also balancing what's happening at home and with family. Tell me if you, as you've been talking to people, or even just your own perspective, you know, we're here in the clinic, and everybody, for the most part, calmly focuses on, here's the science, here's what you do. We got it. Calm. We know what we're doing. But the second they walk out the door, you can't scroll on social media without COVID-19 something, right? You can't have there's no conversation that doesn't have this in it. And unfortunately, all that fear-based stuff is just inundating, and they've got family. And so by the time they come back in the morning, there's an elevated sense, and it takes a little bit to get grounded back in the science and what are we doing. And I feel bad for them. That is exhausting. Don't you think?
I've pretty much quit watching the news.
Oh, I know.
And you know, with the newspaper, actually, I can skip over. I read it much faster than I used to, because I can skip over so much of it. And unfortunately, so much of this is inaccurate and bad information.
I know it.
How about besides moral support, have you had available, have people taken advantage of any kind of counseling or other kinds of
you know, we make EAP, Employee Assistance Program, available for our employees, and we've been reminding them that that's available, just so they can reach out. I have no way of knowing if they have reached out for it or not. Another thing we've done is we had Dr. Wallace come in and speak to the all staff. We do phone side chats where you could either call in or you're stationed appropriately throughout the building so you can hear. And we do that phone side chat. And we had him come speak to all staff, but then stay on and be able to speak with providers directly, so that they could ask the public health director questions, and they could all kind of explore the topic from a medicinal, you know, from the medicine perspective. And that was helpful. That was really helpful. We meet regularly. So executive team meets regularly with all the clinic management. At least twice a week, if not 3 times. We were meeting daily at the beginning, but we've backed that up to twice, if not 3, to hear what's happening, what do you need, how's it going, and then that informs our decision making. We still have an incident command structure in place. We started that on March 11th, but it was twice a day for a couple weeks, and now it's backed off to 2 to 3 times a week. But it's still in place. We're still following that.
That's with following up reported incidents? Well,
it's incident command structure. When there's a crisis, you have one incident command officer, and then you have someone who's in charge of logistics, and someone who's in charge of planning, and someone who's in charge of communication. And that team meets to assess, what did we learn from last night? Where are we at? What do we have to do to make decisions? Do we have enough PPE? Do we not? And it's not necessarily me leading that. It's Omar Gutierrez who's leading it for us. So it's a emergency preparedness structure that you put in place. We did the same thing when the flood hit in Evans. So.
Okay, and it sounds like it's working.
It is. I am very pleased with how well that has worked. I'm very pleased with how in tune, how closely connected we are to the Office of Emergency Management, both in Larimer and Weld. So pleased with how close we're connected to the health department, to the hospitals. We were not appropriate to be an alternative care site that needed to be set up, but we have stood closely by them, let us know if we can help. Can we send interpretation support? Can we help staff? We have not been called upon to do that, but we stand ready to. We reached out to JBS as soon as we were hearing from, like, we heard about the challenges through the patients before I think it got the bigger perspective or the bigger focus here in the community. So we reached out right away saying, we are open, we have walk-in, send people our way if they are ill. How can we help you if you do mass testing? How could we help you with interpretation support? And then we also raised our hand to say, if your employees are needing some sort of screening, the ones who have been out ill need a screening appointment to be able to go back to work, don't go to the emergency rooms for that. Come to us. We will set up a return to work screening clinic, because that we cannot have stuff like that hitting the EDs when they are up to here with everything else, right? So we've been trying to stand strong in that space.
Parenthetically, seeing as how, who knows, maybe some historian is looking at this 50 years from now. JBS is the beef plant in town that had a huge incidence of coronavirus and some deaths, and has been closed, and is closed as of talking right now. And Mark Wallace, who was mentioned, is the director of the public health department as well as a regional health entity. Okay, so another question I have is both for you administrative people and also for the clinical people, what sort of support are you getting in staying informed about best practices? Are you getting it from which brand, who oversees you in the government? Are you getting it from them? Is there a physicians and nurse practitioners group, et cetera?
Yeah, so our chief medical officer and our clinical compliance nurse are closely watching the World Health Organization, but primarily the CDC and the Colorado Department of Public Health and Environment, and then what our two local public health departments are doing that we're closely linked to, Weld and Larimer. And then they are assessing those guidelines, and then making sure we're in compliance. It's been a challenge though, and I in no way mean this to be critical of the CDC or CDPHE, because everybody is building this plane as we're flying it. I understand it. But the guidance they change often. They're muddy when they change. There's not always been, you shall, you must. You could consider, please think about. All that grayness causes problems. Right. You know, I think it's intended to be supportive so you have some leeway, but it is a challenge then. We pay close attention to DORA on the dental side to see what we are eligible to do for dental services. And they are paying attention daily for the HANS, the health advisory notices. But then every week, even if they've watched and there's been new things that come out at the end of the week or the beginning of the next week, they stop and go back and look at them again. It's not, I don't know if you've gone to the CDC website, there's so much information that you have to dig and look, and one page says one thing and another page doesn't quite align. And so it has not been easy.
So does the clinical part of that fall on your chief medical officer?
Yes.
And
yes.
And I know that Leslie had left not that long ago.
No, she's still here.
Oh, she is.
She is. Her last day was supposed to be maybe today even, but she's going to stay one more month. Okay. I asked her to stay. She was happy to stay. She's moving to Summit Stone. They were happy to let her stay, because changing that clinical leadership in the middle of this would have been very detrimental.
Yes.
So she's staying one more month.
And she'd be very good at that. She's leading keeping people clinically informed about.
She is. She and Samantha Orozco is our clinical compliance nurse. The two of them are dialed in closely to what are the requirements, what are the regulations, what's recommendation versus regulation. You know, they're managing that, but they also are helping us with operational decisions, what is appropriate to have in the clinic versus not. When there's gray areas, how are we going to interpret this? What do we need to make sure that our staff is safe and to make sure patients are safe? And that's fallen squarely on the chief medical officer, the chief dental officer, and our clinical nurse admin.
Okay, good.
Yeah.
So that's
yeah.
the structure for that. Well, is there something else you'd like to say or something you want to ask me about?
I will forward to you, I don't know if it's just out of interest, you might be interested. I'll forward to you a newsletter that I did at the beginning of this week, just so you kind of get a sense of everything we're doing. What would I say? You know, I was interviewed by 9 News this morning, and at the end of it, he said, what do you want people to know about community health centers? And I answered something to this effect, that community health centers, there's 21 across Colorado. We care for over 800,000 people. And most of those people are struggling with low income. Support your community health centers. They're standing steady in this storm. If you can donate, please do. All of them are 501c3s. Call your legislator and express your support for community health centers. And mostly, please follow what the recommendations are to help slow this disease. And I'm asking on behalf of the frontline workers, our healthcare team, they are counting on people to do the right thing. At the hospital, here at Sunrise, across the state, please follow the regulations. And that's how I ended the interview.
Well, I thank you very much for your time.
Well, it's really good to see you, Mark.
Same here. Same
yeah,
here.
I'm so glad you're well, and thanks for thinking of us and reaching out.